This presentation aims to give you an overview of the anatomy, physiology and pathology of the renal system as a prelude to the more specific lectures on the pathology of this system. And so the aims are firstly to review the structure and function of the renal system, and then explain the role of the functional unit of the kidney, which is the nephron, and how it might go wrong, to understand some terms which are pre-renal, intrarenal and post-renal in the context of kidney damage or kidney injury, and finally to list some common disorders that affect the renal system. So let's think about what the renal system does. Its primary function is to remove waste products from the blood by filtration. We'll consider that in the next few slides. The other thing it does is it regulates the levels of ions in the blood, which are critical for normal function. And so kidney disease can be associated with ionic imbalance within the blood. It's also important for the regulation of blood pH. And so indirectly it will affect respiration as well. It can regulate blood pressure because it secretes a hormone, renin, which you've come across in the context of the renin-angiotensin system. It regulates blood glucose by either allowing the blood glucose to be excreted because there's just too much, or selectively reabsorbing blood glucose. So it's critical in the regulation of blood glucose. It also secretes a couple of hormones. One is calcitriol, which is concerned with calcium metabolism, so that will affect bones. Occasionally, kidney disease is associated with bone problems. And also erythropoietin, which is a hormone that's essential to stimulate the bone marrow to produce blood. So kidney disease can be associated with anemia as well. It'll remove excess substances. So if they're taken in excess, for example, too much water produces copious amounts of dilute urine. Vitamins, for the most part, for people on a normal Western diet, the vitamins that are bought in the shops are peed out quite soon after they've been taken because they're taken in excess. And finally, it will remove toxic substances from the blood as well, so the excretion of drugs. So quite a long list of functions of the renal system. And the 2 points I've made at the bottom here concern the anatomy of the renal system. In females, the urethra and the vagina are separate, and so the genital and the urinary ducts are separate. And so it's possible to have a urinary tract infection, perhaps even a kidney infection as a consequence, in isolation and not involving the genital tract. In males, the urethra is a shared duct for the genital tract and the urinary tract. And so a urinary tract infection in the male can ascend and affect the prostate and then the testes. So a difference there between males and females. Males have 2 separate ducts, males share 1 duct. So let's have a look at the anatomy of the renal system. I think one of the points that should be embedded into your consciousness is that the kidneys receive a lot of blood. It enables them to perform their function as filtration units, but it's a double-edged sword because if the blood supply to the kidney is impaired, the kidneys suffer, and so reduced blood supply to the kidney can cause kidney damage, often very acutely, perhaps after surgery, that kind of thing. Acute dehydration, which will reduce the blood volume and the amount of blood that gets to the kidney as well, can cause kidney injury. If we look at the kidneys, you can see 2 kidneys there. One's a little bit lower than the other, in theory, not in this diagram, however. Maybe. The kidneys lie on the posterior abdominal wall, so they're quite deep. One on both sides, and they're supplied by the renal arteries from the aorta. That's that bright red structure in the centre. And they transfer the urine that's been produced via the ureters, which are again on the posterior abdominal wall, and they travel all the way down to the pelvis where the bladder is located, and that's where the urine is stored, and there are sphincter mechanisms to prevent the urine from escaping, but these can be overridden consciously so that the urine can then escape via the urethra, which opens to the outside. The kidneys are primarily involved in what's called glomerular filtration, that is pushing a filtrate from the blood, which is pushed under hydrostatic pressure into the functional unit of the kidney, and then it's modified before it eventually ends up in the ureter. So quite a lot of excretion and absorption, so there's modification of this glomerular filtrate before it ends up as what we would call urine in the ureter. Storage is very important, and if that's interfered with, then there can be problems. A common condition in older men is a benign enlargement of the prostate gland, which is at the base of the bladder, and that makes urination or micturition difficult. If that becomes occluded, the urethra, then you have an obstruction, and that's an emergency. So let's have a look at some of the things that can happen to the kidney. Kidneys can be damaged through no fault of their own, if you like. So if the blood supply to the kidney is impaired, kidney damage can follow. So that kind of kidney injury is often referred to as pre-renal. So no fault of the kidney, but the kidney does get damaged as a consequence. There are other types of kidney injury which are within the kidney itself. So infections, an immune attack, and so on, that might affect the structure of the kidney itself. Then that is called intrarenal kidney damage. And then if we start with the collecting ducts and the renal pelvis, the ureter, down to the bladder and the urethra, damage to those structures can also affect the kidney, primarily because they impede the flow of the urine out of the kidney, and so it then backs up into the kidney and can cause a swelling and edema, cysts and so on, conditions like hydronephrosis. So if the urine is backing up into the kidney, perhaps it can't get into the bladder very well, but it's still being produced, it will back up the ureter and back into the kidney and cause kidney damage. So that's called post-renal. So there are three concepts that are often used in the context of kidney injury. So let's move on. We'll still consider where the kidneys are, but we'll consider the surface anatomy now. So those kidneys on the left there have been drawn a bit shakily on someone's back, so you can see roughly where they are. One handy way to do it is to find the first lumbar vertebrae and just draw a line, and the kidneys are roughly at that level, at least the hilar of the kidney where the vessels and the ureter emerge are at about the first lumbar vertebra level. And knowing where the kidneys are can help you maybe make a differential diagnosis of something like back pain. So most people with back pain have got a bad back, and that's it. It's a musculoskeletal problem. But on occasion, the back pain can have another cause, a visceral cause. And part of a workup for someone with back pain might be to tap them. It's called Murphy's punch sign. It's actually not as violent as it sounds. Tap them in the region where you know the kidneys are. And if the kidneys are inflamed and tender, then that elicits pain. And so that could be one clue that there is a problem with the kidney. And patients may actually complain of loin tenderness, in which case the possibility of kidney disease should be considered, along with everything else. Let's move on. The kidneys don't always look like they are in the books. And so what we've got here are kidneys that are going to be functioning perfectly well, but they don't look right. On the left, we've got a situation where one of the kidneys has failed to develop, and the other one has taken over the function. When that happens, or perhaps a kidney is removed because of disease, or perhaps even a transplant, the remaining kidney tends to be larger to compensate for the function. If you look at the middle, we've got two kidneys, but in development they touched each other and fused, and because the kidneys start off low down in the pelvis, it prevents the kidneys from rising up to their normal position, which is in the mid-lumbar region, and so the kidneys remain near to the bladder and connected, and they work fine. It's just they're in a different position to normal. And finally, another developmental abnormality shown in the artist's diagram on the right. Occasionally one kidney may stay in the position where it was in the embryo and the fetus, down in the pelvis, and fail to rise up to its adult position, and in which case that's going to work fine as well. So kidney position can vary, and kidney appearance can vary as well. So let's have a look at kidney structure in just a little more detail. Here we've got a kidney, and we can see it's got an outer cortex and an inner medulla. So with the naked eye, this can be seen, and you could see in the medulla there are sort of triangular areas that lead into the centre of the kidney. These are called pyramids, renal pyramids. At the apex of the pyramid is where the urine emerges. So if we look at the enlarged diagram, you can see that in the renal cortex we've got a collection. If we start with number 1, the renal corpuscle. This is a ball of small capillaries surrounded by another structure that can receive a filtrate from those capillaries, and that filtrate then enters the tubule. The first part of the tubule is called the proximal tubule, and it wiggles and winds, and it's often referred to as a proximal convoluted tubule, and lots of reabsorption and a little bit of secretion occurs in there. And then that proximal tubule leaves the cortex and now enters the medulla as a tubule that forms a loop. It's called the loop of Henle, where quite a lot of water reabsorption is taking place, and goes back up into the cortex, where we've got the distal tubule, which is convoluted again. Quite a lot of water reabsorption happening there, and by the time the distal tubule enters the collecting duct, that's a common duct for lots and lots of nephrons, urine is being secreted into that duct, into the collecting duct, and will eventually dribble out at the apex of the pyramid, so that's at the bottom of this diagram, as urine into the centre of the kidney, which is, there's a dilated space there, and eventually all of that is going to pass into the ureter. So that's a general organisation. We've got a cortex and a medulla. The cortex, most of the nephron is in there, and the medulla contains the loop of Henle and the collecting ducts. So let's have a look at the nephron, which is a new term, which is essentially that most of that blue structure that you can see in this diagram. We'll look at it in a bit more detail, because that is the functional unit of the kidney. So it might look like a complicated side. Let's start with the yellow structure. Okay, the top part of it is labelled glomerular capsule, sometimes referred to as Bowman's capsule. That leads on to the rest of the renal tubule. So you remember there was a proximal tubule, then a loop of Henle, then a distal tubule, and the distal tubule drained into the collecting duct. All of that is simply being represented by one tube, even though we know it's quite convoluted. That's almost all of the nephron here, that yellow structure. But for the nephron to function, it needs to receive filtrate from the blood. So we're now going to start with the blood. You can see that we've got branches of the renal artery over there on the left of the diagram, which are going to branch and branch and branch as they enter the kidney to finally produce very, very small arteries, arterioles, which then form a loop encapsulated by this glomerular capsule or Bowman's capsule. And under pressure from the blood, fluid is squirted out from there and enters the Bowman's capsule or the glomerular capsule. That filtration travels down the nephron, and at various points materials are reabsorbed back into the bloodstream. Can you see that the afferent arteriole then became an efferent arteriole, and then eventually lost most of its smooth muscle and became a vein, a venule, but kept winding round the nephron, so it was very closely related to the nephron. So it's in a position to take back some substances that were which were filtrated from the glomerulus. You can see on the diagram we've got the glomerular capillaries. It's a ball of capillaries. There's a little bit of pressure, not a massive pressure, a little bit of pressure, and that forces the fluid out into this tube, and then we've got reabsorption back into the venules to go back to the body, but we've also got a little bit of transport from the venules and secretion into the tubule itself, and the combination of reabsorption and secretion as material is passing through the nephron finally results in the production of urine. So that's how it functions. Let's think about how this structure and function renders the nephron vulnerable to injury. The first thing is that there are many, many capillaries, and they've got a basement membrane, which is a kind of proteinaceous sludge around the outside of the capillary in the kidney. And it receives an awful lot of blood, about a quarter of the cardiac output. So if there are diseases that are going to affect blood flow, might be hypertension, it could be that there's been loss of blood with a hemorrhage, it could be that the capillaries are affected or the basement membrane is affected, and in conditions like diabetes, where there's uncontrolled levels of glucose, the capillaries and basement membrane structure can be altered so that they don't function correctly, and that will affect the kidney as well. So the fact that the kidney's got a lot of blood vessels, a lot of capillaries and a lot of basement membrane means that any disease that will affect capillaries, blood flow or basement membrane will affect the kidney. If we look again at the glomerulus, it's a ball of capillaries, and we're assuming that that remains intact and simply squirts out a filtration into the Bowman's capsule. If there's damage to the glomerulus, those capillaries can become leaky and release red blood cells, which can then enter the glomerular capsule, which can be damaged as well. And so if there's blood in the urine, that's a sign that the glomerulus may be damaged. I think we'll leave that slide at the moment. So that's the nephron, which is the functional unit of the kidney. What we'll look at in the next slide is just how this filtration from the glomerular capillaries to the Bowman's capsule actually occurs. Right, so if we start with the diagram, right on the left, where it says endothelial cell with fenestrae, and there's an arrow that says filtration, that would be the blood. So you're inside a blood vessel at position A. So that would include all the components of the blood plasma plus the cells that you'd expect in the blood. And you want to get materials from A to position C, which is inside the Bowman's capsule. And to do that, we pass through a few filters. The first thing is the endothelial cell, and that's a pretty severe filter. It will keep back blood cells and those tiny little fragments called platelets that are very important for clotting. You see it's got small pores in the endothelial cell. So pretty much every molecule can get through there, but if it's a complex structure like a platelet or a blood cell, this coarse filtration by the endothelial cell will keep back the cells and the platelets. We then hit the next stage of filtration, which is B, which is this sticky, gooey, proteinaceous substance. It's a matrix full of things like glycosaminoglycans and proteoglycans. Trying to think of an example of what it might look like. Jelly. I think jelly is a good term for that. This is the basement membrane. So it's a molecular sieve, if you like. So all the materials that have come out of the blood, which would exclude the cells, now enter this molecular sieve. And so large molecules, like the large plasma proteins, can't get through the basement membrane. But important things can. Certainly glucose is going to get all the way through to the other side. And then finally, we've got filtration slits between the cells that help to form the Bowman's capsule. These are called podocytes. And the blue and the green ones are exactly the same. I don't know why they've coloured them indifferently in this diagram. And we've got a final stage of filtration where anything more than about 70 kilodaltons is kept back. The proteins and molecules less than that molecular weight can get through. And this is reasonably important because we now have a 70 kilodalton protein which is on the threshold of either getting through or not getting through. And that protein is albumin. So albumin only just manages to be kept in the blood and not put into the glomerular filtrate, but only just. So tiny, tiny changes in the kidney, which probably wouldn't produce any damage, can lead to the presence of albumin in the urine. In some individuals, simply standing up for a long time can lead, because of the hemodynamic changes in the kidney, that can lead to albumin getting through temporarily into the urine and being excreted, and that causes the urine to have a cloudy appearance and so on, and make people very, very anxious. But albumin occasionally occurring in the urine isn't too much of a problem, but clearly if there's severe albuminuria and it's happening all the time, then it points towards a problem with the glomerulus, and albumin is one of the components that's tested for in an analysis of urine. So we've got three stages to filtration: coarse filtration with the endothelial cell, a fine filtration with the basement membrane, and an even finer filtration with the podocyte slits into the Bowman's capsule. And while we're here, we've got endothelial cells, that's blood vessels. Problems with the blood pressure and with blood vessels can affect filtration. B, basement membrane. Anything that might damage the basement membrane. It could be glycation as a result of diabetes. It might be an immune attack on the basement membrane, for example, in systemic lupus erythematosus, so SLE. Let's move on, and we'll have a look at, we're continuing this theme of, we've got blood vessels in the kidney, and that means the kidney is likely to be damaged if there's a problem that affects blood vessels. We'll move on to causes of kidney failure here. If you look, the most common cause, at least in the States, and it probably applies to Australia, 44%, diabetes. Okay, diabetes has a major effect on certainly small blood vessels, and it affects basement membrane. And you remember the kidney's got small blood vessels and basement membrane. That kind of explains the involvement of the kidney in diabetes. If we move on to the next one, high blood pressure. High blood pressure can lead to the development of other problems within blood vessels with atheroma, and the high blood pressure itself can damage small vessels, and so the kidney is vulnerable there. And then we've got the other conditions which I won't mention, but I've mentioned diabetes and high blood pressure. And I've just noticed glomerulus is spelled wrong on this slide. So let's move on to how glomerular filtration is actually regulated. Okay, so normally we've got about 100 ml of blood flowing through the kidney in a minute. That's a lot of blood. And so if there isn't enough blood, that will mean that not as much blood is flowing through the kidney, which means you get less glomerular filtrate. And the glomerular filtration rate is a critical indicator of the health of the kidney. The kidney itself, though, is quite clever. If the kidney realizes that perhaps not quite as much blood is going to the kidney as it would like, it can dilate its own blood vessels to let a bit more blood come to the kidney. You can dilate those little arterioles which are leading into the glomerulus. So you remember the afferent arteriole leading into the glomerulus, and vice versa. We can constrict those blood vessels to reduce the blood supply to the kidney a little bit in order to regulate the flow through the kidney. That happens on a sort of minute-to-minute basis. But if there's an acute, severe event, let's suppose that there's been a large loss of volume, there's been a bleed, so you've lost blood, which will reduce the blood volume and so on. There are many other detectors in the body that will detect blood pressure and blood volume, and they'll activate the sympathetic nervous system. So the kidney receives sympathetic nerve innervation, and that can affect those little arterioles that are regulating how much blood flows through the glomerulus, and that can alter glomerular filtration rate. So if you go to the box on the right, which is in red, this is the sequence of events that might follow a severe hemorrhage. There'll be a massive loss of blood, then the extracellular fluid volume is going to decrease. If you haven't got as much volume in your blood, then the pressure that can be developed, so there's not as much blood going back to the heart, so it can't be pumped out as well, so the mean arterial pressure would decrease. There in the carotid sinus, there are pressure receptors. They're going to pick up the fact that the mean arterial pressure has gone down. That will activate the sympathetic nervous system, which will then send a message to the kidney to constrict the afferent arteriole. That means that the glomerular filtration rate is now going to be decreased, which means you're going to produce less urine, which is a good thing if you haven't got that much fluid in your body to begin with. Okay. And as a measure of what might be happening in terms of the body and fluid levels and so on, after surgery where there may have been blood loss, urine output is commonly measured, and it's the box on the right that helps you understand why anyone will be worried about urine output after surgery. Okay, let's consider glomerular filtration in a little bit more detail. If there's a problem with the kidney, and you remember albumin was just on the cusp of being kept in and maybe not being kept in, but for the most part it was kept in. If albumin is lost and then other plasma proteins are lost because there's damage to the kidney, and so the plasma proteins appear in the urine, then those plasma proteins are not in the blood, which means the osmotic potential of the blood, how thick the blood is, if you like, is reduced. And the osmotic pressure of the blood is actually quite important, because it does help to suck water from the extracellular space, that's the interstitial fluid, back into the blood, and so you don't become edematous. However, if you've lost proteins from the blood has less power to pull water from extracellular locations, so that's the interstitial fluid, in, and the result is edema. And so kidney damage can result in edema. And on the right you can see a pitting edema at a dependent part of the body there, and also in the face with kidney disease. Very often there's edema around the eyes, and the lips may be swollen, so edema in the face as well. Here, there are many causes of edema, but one cause could be kidney disease. Okay. So clearly, this glomerular filtration is very important. It's going to help to regulate your fluid levels and your blood pressure. It's going to regulate what's passing out from the blood and into the urine. So let's consider a few mechanisms by which the glomerular filtration rate is altered. So one is this local mechanism, whereby it's kind of a reflex contraction. The arterioles are stretched, perhaps because of an increased pressure, increased blood volume, and in response they constrict, and they then reduce the glomerular filtration rate. So that's like a local reflex action. There are special cells, which we won't go into detail with. They're called juxtaglomerular cells. That's difficult to say when you've just woken up, in the kidney, and they would normally release a vasodilator called nitric oxide, and if they're stimulated, they stop releasing it, which effectively constricts the afferent arteriole. And if you're not getting as much blood into the glomerulus, then not as much is filtered back into the Bowman's capsule, and the net result is a decrease in glomerular filtration rate. So that can be affected by hormones as well. Finally, we mentioned in the previous slide that the sympathetic nervous system can act on the afferent arteriole and cause vasoconstriction and decrease the glomerular filtration rate. Very handy if you've already lost a lot of fluid in your blood. The last thing you want to be doing is losing even more fluid by producing a lot of urine. And finally, there are a couple of hormones that can act on the kidney. In fact, I've only got two here, but there are other hormones as well. Here for the glomerular filtration rate, angiotensin II can decrease it, and this peptide, atrial natriuretic peptide, that's produced by the heart, can increase the glomerular filtration rate. So we've got 4 different mechanisms of regulating the glomerular filtration rate. So now we know we can regulate how much is going through the kidney. Let's consider what happens when this filtrate gets into the tubules, because an awful lot of good stuff is present in the filtrate, and there may be additional bad stuff that you want to add to the filtrate, and all of this is carried out in the proximal tubule, the loop of Henle, and the distal convoluted tubule. So we'll work our way through those parts of the nephron in the next few slides. So here's another diagram of a nephron. We can see the red tube on the left, which is a branch of the renal artery that's entered the kidney to give off a tiny, tiny little arteriole, which then forms a bundle of arterioles and capillaries, the glomerulus, in the glomerular capsule, as it's called on this diagram. And so we're going to get a filtrate from the blood into the capsule, the Bowman's capsule, and then that would enter the proximal convoluted tubule. The proximal convoluted tubule is very, very active. If you look at the cells in the proximal convoluted tubule, they're packed full of mitochondria, which tells you that they need a lot of energy for something. And that energy is primarily used for transporters, enzyme-like molecules that help to push substances, often against the concentration gradient, into the lumen of the tubule, or perhaps even pull molecules back into the blood. Glucose is one molecule that for the most part is pulled back into the bloodstream via a transporter. And all of this selective absorption and secretion demands an awful lot of energy, and that occurs in the proximal convoluted tubule, and with it, it's quite a lot of movement of water, and for the most part, the water is moving back into the bloodstream. Then we've got the loop. Can you see that the loop is surrounded by blood vessels? Very important. For the most part, this loop of Henle is involved in the absorption of water. In order to do it, salt sodium chloride has to be moved into the region outside the loop in order to help to suck the water out. And the arrangement of the loop as well is quite handy, in that the one part of the loop can actually assist the function of the other part. But we won't go into details of that. But the loop of Henle, absorption of water, and also secretion from the blood into the tubule of urea. So we're getting urea added to the filtrate. So we haven't got urine yet. We're modifying the contents of the tube, but it isn't quite urine yet. Then we get to the distal convoluted tubule. It's thinner, but it's got some important functions. It's absorbing water, it's absorbing ions, and so on. And the concentration of the filtrate is getting higher and higher. And then finally we get to the collecting tubules, which absorb a little bit of water and some ions and so on. And they can be affected by a couple of hormones, aldosterone from the adrenals and antidiuretic hormone from the posterior pituitary. And so all along the route here, we've got mechanisms for regulating absorption and secretion into this tubule. Okay, so let's consider the proximal convoluted tubule just in a bit more detail. So its main function is to take water back. And then it also reabsorbs an awful lot of important things that the body might not want to lose in the urine. For example, sodium, chloride, potassium, some ions, glucose reabsorbed, lactic acid comes back. I put some vitamins, which is true. If people take vitamin supplements, mostly the vitamins are not needed, and so they won't be reabsorbed back, and bicarb is going back. Some of this will follow a concentration gradient, some of it will need an active transport mechanism, hence the mitochondria. And surprisingly, about 40% of urea and uric acid is reabsorbed. It's going to get back into the urine later on, but at another point in the tubule. And creatinine is not absorbed at all. One point that I've mentioned at the bottom here is that there is a threshold beyond which the transporters of glucose, they're called symporters, just can't cope. And so if glucose levels are too high, glucose will really not be reabsorbed effectively. And so glucose is going to continue on down through the nephron, through the tubule, and be expelled along with the urine. And so the presence of glucose in the urine can either tell you that there's something wrong with the kidney or something wrong with the levels of glucose that are arriving at the kidney. For example, in diabetes, where glucose levels, blood glucose levels, can't really be controlled that well. And en route, the presence of the glucose in the blood can cause all kinds of problems in the kidney. Okay, that's the proximal. The next bit is this loop, which we'll consider reasonably quickly. Here's a loop of Henle. You can see glomerulus at the top, and it loops down into the medulla of the kidney, and we can see it's surrounded by blood vessels. And we can see movements of sodium chloride. And wherever you put the sodium chloride, water is going to follow because it will increase the osmotic potential of the interstitial fluid and so on, and also we've got blood vessels flowing through there as well. And this is a nifty mechanism for removing water from the loop of Henle. And there are a number of chemicals that have been identified, drugs, which can act on the loop of Henle. Most of them that are used increase the effectiveness. Actually, I should rephrase that. I was going to increase the effectiveness of diuresis. They're actually decreasing the effectiveness of the loop of Henle so that less water is reabsorbed and more water is present in the urine. So these diuretics are going to help the patient produce more urine, which removes water from the bloodstream. And there are a number of conditions where it's advisable to reduce either the blood volume or to remove water from interstitial fluid, so hypertension and edema. So some diuretics are going to act on the loop of Henle. Let's leave that and we'll move on to the distal tubule. We've been absorbing water all the way, proximal tubule, distal tubule, and you'd be thinking, well, we must be done now, but no. There's still a small amount of water which is absorbed in the distal convoluted tubule, and this hormone that's produced from the adrenal, the aldosterone, can increase water absorption. In addition, the renin-angiotensin system, which we know has got an effect on blood pressure, increases water absorption in the distal tubule, so that's going to increase the blood volume. The posterior pituitary can act on the distal tubule to increase water reabsorption as well. There are a couple of things that can decrease. Atrial natriuretic peptide can decrease water absorption. And finally, there are parathyroid hormone from those glands on the back of the thyroid gland, and they can increase calcium reabsorption. So what does all this mean? Well, with all this talk of water reabsorption, problems with the kidney can often be associated with edema, and we can link that back down to retention of fluid, but also if we've lost plasma proteins as well, that would be an explanation for the edema. And we've seen how various calcium metabolism is critically affected by the function of the kidney, and so bone problems can occur as a result of kidney damage. Let's move on to, I think, diuretics. Okay. Things that are going to increase the amount of water in the filtrate and reduce the amount of water that is reabsorbed and therefore increase the volume of the urine. A couple of these that I've mentioned, the first two, are acting on the loop of Henle, and so they're often referred to as loop diuretics. Alcohol, most people have know of a friend at a different school of nursing who was drunk alcohol once or twice, and one of the effects of that is that they may go to urinate a bit more often. One of the effects of alcohol is it inhibits this anti-diuretic hormone. So if you haven't got any anti-diuretic hormone, you have diuresis here. And finally, caffeine, commonly consumed. Somehow it increases the glomerular filtration rate. I've done a little bit of digging, and I have to say that there's quite a lot of confusion about the precise mechanism by which caffeine increases the glomerular filtration rate. And clearly, if you filter more fluid, you get more fluid in the tubule, and if that isn't followed up by absorption of more water, then there'll be an increased volume of urine that's produced. In terms of usefulness of diuretics, then if someone has high blood pressure, reducing their blood volume, so the heart's got a little bit less to work with, can lower the blood pressure. And so diuretics are also used in combination with other drugs and strategies in the treatment of hypertension. Okay. So there we are, kidney and hypertension. The kidney has an influence on many systems and functions. Let's move on to urine itself. So with the urine, one thing that's of interest is how much is being produced. So the production rate, that can give an indication of how well the kidney is functioning. It could be a pre-renal cause, it could be just there's not that much fluid getting to the kidney. It could be an intrarenal cause, it could be because the kidney is damaged, it could be post-renal. The urine is being produced, but it's not getting down the ureter or into the bladder or out of the bladder into the urethra or out of the urethra. There could be a stricture in the urethra. So the amount of urine that's produced is important, but it doesn't really tell you where the problem might be. We can look at the specific gravity of urine. Often just looking at the colour of it can tell you whether it's concentrated or not. And in the past few slides, we've considered many mechanisms by which the concentration of urine is modified. So it's modified by the amount of water, essentially, that's present in the urine. And so that's a function of the proximal tubercle, the leukophengly, the distal convoluted tubercle, and so on. We can look at things like nitrites in culture. Bacteria can produce these nitrites. And of course, if you culture the urine, you may see the development of a colony. And that can be useful in the diagnosis of infections of the urinary tract. Glucose is commonly measured as well, and that can either point towards a problem with the kidney because it's not able to reabsorb glucose normally, or it could be another problem in which levels of glucose that are entering the kidney in the first place are so massively high that the kidney just can't cope with these large amounts of urine. We can also look at protein in the urine as well, which does indicate a problem with the filtration capacity of the kidney. Albumin is a commonly detected protein and can indicate kidney damage. Might even be secondary to diabetes. And if there's blood in the urine, then that would indicate a problem in the region of the glomerulus, so that those endothelial cells with their little fenestrae are not able to hold back the red blood cells and the platelets, and they're leaking through, and the whole thing is getting through into the glomerular filtrate, and that would indicate kidney disease. And there are many other things that can be analysed in urine as well, but this is just a sample of some of the things. We've actually moved to the collecting ducts now, so we're looking at the collecting system for urine and some of the problems that can occur once the urine has been produced, and we'll consider these in the next two slides. So we've got a kidney, and right in the centre of the kidney, this sort of dirty yellow colour, it's called the renal pelvis, is where the urine from all of these renal papillae and so on has been expelled and is being collected, and so on. And then the urine is going to pass down the ureter and into the bladder. The thing about the way the urine gets from the kidney to the bladder is that it doesn't just dribble in through the effects of gravity. Otherwise, people who went up into space would never fill their bladders. In fact, it's quite difficult to get the urine down the ureter and into the bladder, because at the point where the ureter enters the bladder, it enters through muscle, and it enters at an angle so that the ends of the ureter are squashed shut. And you'll be thinking, well, that's a bad idea. How's the urine going to get into the bladder? The way the urine gets into the bladder is there's smooth muscle along the ureter, and it undergoes peristalsis, very much like what happens in the esophagus when you swallow something. And so urine is squirted into the bladder periodically. That's how urine gets into the bladder. So now look at some of the problems that might happen. With severe dehydration or problems with calcium metabolism, such as high levels of calcium, which might predispose to the formation of a stone. We can get stones in this part of the tract here, in the pelvis or the ureter or the bladder. So these are called renal stones. If we go up to the kidney where the renal pelvis is, and a little bit higher up where the renal calyces are, so if you look at the diagram, the large diagram of the kidney here, you can see right in the centre it says renal pelvic stone, and then nearer to the pyramids we've got a calyceal stone in the calyces. These can often be present, can be seen with an X-ray or a CT, and they've been asymptomatic. They don't cause a problem. They can, but very often they're present. There are so many other areas, and the urine can dribble either side here, and so the person is carrying a stone in their kidney, but it's asymptomatic. Often, not always, but often. The problem comes when the stones then move, maybe from the pelvis region, which is quite a large area, and then enter the ureter, because the ureter is a smaller diameter than the pelvis, and so there's then a chance that the stone can get stuck in the ureter. And you remember that I mentioned the urine gets into the bladder by peristalsis. So imagine what it's like if you've got a stone in the ureter which is stuck, and then the ureter attempts to squeeze around the stone. That creates intense pain, and it's often associated with vomiting. And that's referred to as renal colic. And the pain occurs while the ureter is contracting for its peristalsis, but then it'll wane, it'll wax and wane, so it'll come and go. And that's characteristic of the pain of renal colic. And of course the pain is associated with the loin region as well, where the ureters would be, or the kidneys might be. And these stones can occur in the ureter, and there's certain sites along the ureter where there's a bit of a kink or a constriction of the ureter because of anatomical structures. It might even be a pregnant uterus in the way. And so there are characteristic sites where these stones can often just become lodged. And so on an X-ray, that would be where the radiologist would look for the calcified structure. They can be removed surgically, and they can also be removed by directing microwave or ultrasound, sorry, not microwave, that would cook your kidneys, ultrasound waves into and directing them onto the stone to jiggle the stone and rattle it around. And if that happens enough, the stone can break up into smaller pieces, and the sand can then be urinated out. And that avoids having to open the person up in order to remove the stone. So that's called ultrasound lithotripsy. I do remember seeing an instructional video on that by an American. They managed to, the Americans always make things difficult, and they called it extracorporeal percutaneous ultrasound lithotripsy, followed by some dramatic music. Anyway, so directing ultrasound onto the stones to jiggle them and turn them into sand is one way in which kidney stones can be removed. Let's move on to another route. So that would be a post-screen. If those stones remain in place, urine will still be produced and it will back up into the kidney, and that will cause kidney damage. But that's a post-renal cause of kidney damage. And let's move to the last slide, which is the storage release of urine. In these diagrams, we've got a male and a female. We've got a female bladder and a male bladder at the top, and they lead out into the ureter. In fact, they don't lead into the ureter at all. So my apologies there. I'll try and change the slides that are uploaded. That's a spelling mistake. That's the urethra. Sounds the same. The two little yellow tubes that are leading into the bladder are the ureters that we've just been talking about, the urethra. And the point I wanted to make is that the urethra in the female is a lot shorter than the urethra in the male. And because of the location of the external urethral orifice in the female, which is not far from the anus, with all the fecal bacteria around there, there's an increased chance of bacteria entering the urethra, not the ureter, the urethra, and tracking back. And it's only a short hop from the urethra into the bladder to cause a bladder infection. That's called a cystitis. In the male, the external urethral meatus is quite far removed from the anus, but if it still can receive bacteria and infection and so on, and that infection can just set up a urethritis. On occasion, it'll track all the way back, but it's got a long way to go to give a prostatitis, and then finally, right way up here, is a cystitis associated with bladder infection. So cystitis is less common in males than in females, and the explanation for that is the anatomy, and whatever you do, change that ureter to a urethra in this particular diagram there. So that's infections and so on. The other thing about the female is the uterus is basically sitting on top of the bladder as well, and so that can lead to an increased sense of urgency with urination, also called micturition. And with cystitis, symptoms would be urgency and frequency of urination, but also pain, and that's as the urine passes along the inflamed urethra. I'll get this right, urethra, all the way along. Let's also consider, we'll go back to the male now. In females, constriction and compression of the urethra is rare. It's of a wider diameter, the bladder is just above it, and micturition is just a more explosive activity than it is in the males in any case. So it happens quite well, and it's also quite easy to get a catheter into the bladder. If we move to the male, we've got certain sort of structures near the just near the tip where the catheter can get snagged, and we've got to pass all the way up through the diaphragm and then through the prostate before we get to the bladder itself. So we look at the prostate. You see where it's located. It's actually located around the widest part of the urethra, but in most men over the age of about 60, because of the continued effects of testosterone through life, there's an enlargement of the prostate gland. It's called benign prostatic hyperplasia. And as a consequence, the urethra, as it passes through the prostate, can be constricted. And this happens gradually, but it does mean that it makes it more difficult to pass the urine from the bladder through the prostatic urethra and out again. Initially, you'll get an increase in the wall, the muscular wall of the bladder and ridges on the inside and so on to cope with this problem. But on occasion, the passage of the urine down the urethra could become blocked completely, and that's an emergency. There's also a long urethra in the male that could be infected because of sexually transmitted diseases and so on. And if there's scarring that occurs there, we can get stricture, and that can impair the flow of urine down the urethra, which will mean it will build up in the bladder. I mentioned in the previous slide that the ureters enter the bladder obliquely and have their ends squashed by the bladder muscle, but it isn't a perfect seal. It's not a one-way valve, and so if the amount of urine in the bladder increases sufficiently, the urine can get pushed back into the ureters. It's called vesicoureteric reflux, and then that can damage the ureters and make them wider and so on, and then that can track all the way back to the kidneys and cause dilatation of structures in the kidneys and lead to kidney damage. So in this case, we've got a problem with the expulsion of the urine, which has led to a buildup of urine in the bladder, which is then tracked back up. So this is a post-renal cause, which can then cause kidney damage in itself. So just before you leave that slide, you look at that diagram that says ureter, and you'll say, aha, that's wrong. That's the urethra, and that's a spelling mistake. So what we've done is we've reviewed the structure and function of the renal system, and we've looked at the nephron, which is the functional unit of the kidney, very important. We've looked at the terms pre-renal, intrarenal, and post-renal in terms of how the kidney can be damaged. And we've listed some common disorders that affect the renal system.